So you're very welcome to this evening's webinar, everyone. If you are just joining us in the room now, the recording has started and will be posted on the IAOP website in the coming days. So the topic of this evening's webinar is infertility management, and it's an update for pharmacists. I'm sure many of you have already attended webinars with the IAOP in the past, but just for the sake of housekeeping this evening, as I say, we are recording and your microphones should be muted as you join, but please do ensure they're muted throughout. You can have your cameras on and off as you so wish. We do love to see faces, particularly at the question time, but feel free to do what you wish there. If you are having problems with sound, just ensure your speakers aren't muted, or try leaving the meeting and joining again. We do have some IT support here from the IAOP this evening, so if you're having any particular issues, do just type that into the chat and we can come to assist you. You're very welcome to ask questions, and you can use the chat function for that. If you post into, if you're looking at it on PC, hover on the screen and you'll see a chat function coming up. I see Grace has just posted a feedback survey in there, and so the IAP are always receptive to feedback on this webinar, but also suggestion for future webinars as well, and we'll post that link again towards the end of the webinar this evening, and that feedback is anonymous. So thank you for that. By means of introduction, we're joined by David Fitzgerald here this evening, who is a pharmacist executive manager at the National Maternity Hospital. And I'll hand over to David in a few moments, but just I suppose at the outset to flag one or two issues with you. As you can appreciate, this topic around fertility can be a sensitive topic for some individuals. You might be here in the room with us this evening, or you might have loved ones for whom this is a sensitive topic, and we do acknowledge that, and please do ensure that you access the supports that are available to you if you find this a difficult topic. Secondly, just in relation to kind of the content that will be covered this evening, we're very much focusing on the clinical aspect of fertility management this evening. We acknowledge that there is an administrative aspect to this as well, particularly around high-tech medicines, but we do encourage you, if you have specific queries in relation to that, to reach out to the PCRS as you would ordinarily do within your work. So those are the two things that I wanted to mention before I hand over to David. As I say, David will take us through the slides, and then we will take some questions at the end. So thanks very much, David. I'll hand over to you.
Thanks for the introduction, Mary Claire. I'm just going to share my screen here. 1 sec. To this webinar. This picture here in the first slide is Louise Brown. So Louise was the first, what they call test tube baby. She was born in 1978, and her birth revolutionized reproductive medicine. Since then, over the decades, the medication protocols have become increasingly complex, and pharmacists are essential for their success and their safety. In Ireland, until very recently, we were the laggards of Europe when it came to legislation, regulation, and public funding, or access to public funding for fertility treatment. That's all changed in the last year or so with the writing into law of the Health Assisted Human Reproduction Act in summer 2024, which has led to only last month the creation of AHRRA, which is the Assisted Human Reproduction Regulatory Authority. So this, combined with the rollout of 6 publicly funded fertility hubs, has greatly changed the landscape. So this webinar comes at a very opportune time. Now, while it is a complex topic, and of course I'll be covering all the pharmacological aspects of fertility treatments, I will at the end be giving you a brief update on these changes in the regulatory environment. So as Mary Claire said, my name is David Fitzgerald. I'm the Pharmacist Executive Manager in the National Maternity Hospital. I've been working as a hospital pharmacist for about 15 years, 12 of which in maternity services. Prior to the high-tech hub being launched in 2018, the National Maternity Hospital Pharmacy, we were the main dispensing pharmacy for fertility prescriptions from the Marion Fertility Clinic. So that's a not-for-profit fertility clinic that's affiliated with the hospital. So I started in 2013 in Hall Street. So between 2013 and 2018, we were dispensing around 20 prescriptions for fertility cycles per week. So we got quite familiar with it. My other credentials, I suppose, for giving this webinar is that we are one of the 6 publicly funded fertility hubs. So I'd have a degree of interaction with clinicians there in that fertility hub. Now, we could do a 10-episode series on fertility management. I've had to condense down the material quite a lot to get it across into 1 hour. Very complex. There's a lot of demand for further education in this area. The complexity of the treatment regimens combined with the kind of intermittent frequency at which you receive a prescription in the dispensary of your community pharmacy makes this very challenging, as I'm sure most of you are aware. From a hospital pharmacist perspective, then, doing medicines reconciliation and clinical pharmacy on a patient who's on a fertility cycle or who's recently been on one can be challenging as well. There seems to be a lack of familiarity, and that's understandable. So with that in mind, the purpose of this webinar is to address those challenges for you, and with 4 main learning outcomes. We're going to talk about infertility and its causes and briefly talk about diagnostic criteria. We're going to look at the pharmacological management options. This will be the bulk of the talk. And throughout the presentation, we'll be discussing the pharmacist's role in fertility management and ART, which is assisted reproductive technology. Briefly at the end, then, I'm going to look at the ethical, legal, and counselling aspects of fertility care. So as I said about the legislative, regulatory, and public funding aspect. For anyone looking for further reading, I direct you to the EHRRA, European Society of Human Reproduction and Embryology. So this is probably the best resource you can find to check out, different types of medications, what the evidence base is for them, different types of fertility treatment regimens. Nice to have a good clinical guideline on it as well. If you're looking for something more like a novel, Professor Mary Wingfield, so she founded the Marion Fertility Clinic, and she wrote a novel called The Fertility Handbook back in 2017. It's directed at patients, but it's very accessible, very comprehensive, and goes through all the aspects of fertility management. So it's quite a good one for further reading. In terms of fertility in Ireland, there's no public database that shows how many patients are on fertility cycles. In general, it affects around 1 in 6 couples. The WHO has a definition which is quite broad. It's infertility is a disease characterized by the failure to conceive a pregnancy within 12 months of regular unprotected sexual intercourse or due to the inability to reproduce either as an individual or with a partner. So that's quite broad, and we'll see later on that actually there's a bit more nuance to it. Around 30,000 couples affected in 2022, and it's a major cause of psychological morbidity in Ireland and worldwide. Really important point here is the ability to conceive declines with age. So we're all probably fairly well aware of that and have heard that. But despite the awareness of the effect of age on fertility, the average age of a first-time mother in Ireland has gone from 27 in 2020, in the year 2000, to as high as 32 in 2024, and it keeps on rising. So the average age of a first-time mother is steadily rising in Ireland. And as I mentioned, historically, there's been a lack of legislation and regulation and access to public funding in Ireland, but luckily that has now changed. So before we get into the pharmacological aspects, we're going to go back to our junior cert and leaving cert biology, reproductive biology. So in order for conception to occur, 4 things have to happen. The first thing that has to happen is that a woman has to ovulate. An egg has to be released from an ovary and has to travel through a fallopian tube. Second thing that has to happen is that a man has to generate and release sperm. Third part is that the sperm has to meet the egg. And the fourth part is that the fertilized egg has to implant in the uterus. If there's a problem with any one of these stages or more than one, you've got an issue with fertility. So that's all the basics. If you look at this graph on the right here, so this is the menstrual cycle, generally 28 days, but can vary, can be as frequent as or infrequent as 35 days. There's 3 phases. So the first phase is the follicular phase. So days 1 to 5, the shedding of the endometrium. And you see here, up the very top, you see the follicles. So these follicles in the ovaries, multiple follicles are growing, around 8 to 14 follicles are growing. And this is caused by a hormone secreted from the pituitary gland called follicle stimulating hormone, or FSH. I'm going to refer to this as FSH for the rest of the presentation. And it's really important that you just get this concept first, because all the rest of it will make sense after. So FSH acts on the follicles. Between days 6 to 9, a dominant follicle emerges, and the rest of the follicles start to fall off. This dominant follicle then begins to secrete increasing amounts of estrogen. And this increasing estrogen then leads into the next phase, which is ovulation. So the rising estrogen levels triggers a positive feedback loop in the brain, in the hypothalamus and pituitary, to release a surge of another hormone called luteinizing hormone, or LH. This surge in LH causes ovulation to occur, so the egg is released from the dominant follicle. The next phase then, luteal phase. So the follicle that released the egg becomes what's called the corpus luteum, and the corpus luteum then continues to secrete estrogen, and it starts secreting increasing amounts of progesterone to build up and maintain the lining of the endometrium. If implantation of a fertilized egg or an embryo occurs in this period, it will begin to secrete a hormone called HCG, which is what's detected in the urine test as a positive pregnancy test. If this doesn't occur after about 2 weeks, the corpus luteum starts to degenerate and the lining of the endometrium starts to break apart again, and we start the next part of the cycle. So the really key part here is understanding FSH, LH, and the rising level of estrogen that triggers the LH surge. And also then just remember about progesterone in the last part of the cycle, the importance of progesterone. In the background here, we've got the hypothalamic pituitary gonadal axis, HPG axis. This operates in both males and females. So from the hypothalamus, a hormone called gonadotropin releasing hormone acts on the anterior pituitary to release LH and FSH, which act on the ovaries to cause estrogen and progesterone to be produced. And then these hormones act in both a positive and negative feedback loop. Similarly, with the male system, then same thing applies, except when testosterone is finally produced by the testes, it only has a negative feedback loop, but it's quite a similar setup. The causes of infertility. So we'll start with female causes, and one of the most common one is ovulatory disorders. And ovulatory disorders are divided into 3 types. Group 1 is less frequent, so this is hypothalamic pituitary deficiency of FSH and LH. So this could be caused by excessive exercise, females undergoing excessive exercise, so being too underweight. The next group 2 of ovulatory disorders is by far the most common, and this is mostly PCOS, a polycystic ovary syndrome. In PCOS, there's too much insulin acting on the ovaries, and this causes the ovaries to produce increasing amounts of testosterone, and this testosterone then interferes with the ovulatory cycle. And the next part then is group 3 of ovulatory disorders, and this refers to ovarian failure. So this could be early menopause, or it could be the after effects of chemotherapy or radiotherapy. If you look at endometriosis, so endometriosis crosses the border of both an ovulatory disorder and what's tubal damage. So in endometriosis, cells similar to the lining of the endometrium are growing in places where they shouldn't be growing. They're causing lesions, and these lesions can become sticky and join together and cause adhesions. These lesions could be present on the ovaries, and it could interfere with the ability of the ovary to release an egg. Or there could be adhesions that have formed that have changed the structure of the woman's reproductive system, whereby, say, the ovary and the fallopian tube could be moved apart and the egg can't travel from the ovary into the fallopian tube. So endometriosis is both an ovulatory disorder and it's a cause of tubal damage. But the main cause of tubal damage is pelvic inflammatory disease caused by STIs like chlamydia. It could also be caused by ectopic pregnancies as well. In terms of uterine or peritoneal disorders, you could have things like submucosal fibroids, polyps, things that are interfering with the ability of the uterus to accept an implanted embryo, or implanted embryo. In terms of male causes of infertility, so when you look at sperm quality, there are 3 factors. There's morphology, motility, and count. Morphology is the shape, motility is how well they move, and the count is how many there are. These can be affected by hormonal factors. It could be like brain tumors or hypogonadism, could be previous STIs, previous infection of mumps, certain medical conditions like testicular torsion, varicocele, epididymitis. In a significant amount of cases, as high as 40% of cases, there would be shared and unexplained causes. You see the figure here from factors in the male causing infertility, 27%. So this comes from a document that was produced a couple of years ago in Ireland. But from speaking with clinicians in our fertility hub, they're saying that the cause of male infertility are as high as 40% in our clinic. So it might be underreported, but just to show you that when people think of infertility and you're thinking about the woman, actually a lot of the time it's the man or it's both. By far the most important risk factor is female age. So it's the most critical factor for conception and successful pregnancy, to such an extent that at the age of 35, a woman has half the chance of conceiving as she would have at the peak of her reproductive ability, which would be early 20s. And then as when women go to the age of 45, the likelihood of conception is 1% of what it was when they were at their peak. So it's a very significant effect. Ovarian reserve refers to how many eggs the woman has left. And this can be quite directly measured by testing a hormone in the blood called AMH, or anti-malarial hormone. This can also be done by ultrasound scan and looking at the AFC, which is antral follicle count, where they perform an ultrasound scan and physically count the number of follicles in the ovary. Egg quality decreases over time as well, but it's not as easy to quantify that. In men, sperm quality begins to decrease from the age of 35, but it begins to significantly decrease in quality from 45 onwards. to an extent that there's an increased rate of failure of assisted reproductive technology cycles. The children born to men who are aged over 45 have a higher risk of autism, schizophrenia, higher risk of being born prematurely. So age is the most important thing. If we look at other risk factors for both men and women, obesity is very important. Women who have a BMI over 30 are greatly less chance of conceiving. So that's one of the main interventions, is getting women's BMI below 30 before they begin to conceive. For men, being obese has an adverse effect on sperm parameters as well. On the flip side then, excessive exercise is equally as damaging. So women with a BMI of 19 or under, they don't have enough fat cells to produce and store hormones, so it's very hard for them to conceive. Men who engage in triathlons, marathons, ultra Ironman, all this sort of stuff, this can greatly adversely impact sperm parameters. Smoking is an obvious one. A smoker say who's 35 years of age has the reproductive age of someone who's 10 years old or at 45 years of age. So it has an enormous effect on it, on fertility. For women, if they stop smoking, it takes 3 to 6 months for the quality of the eggs to recover. For men, it takes 3 months for the quality of the sperm to recover. So it is reversible. Alcohol is not an absolute no-no. Studies have shown that small to moderate amounts of alcohol have no effect on fertility, but once you get to the moderate to high levels of alcohol intake, there is an impact on fertility. So alcohol can be taken, but in moderation. Stress per se doesn't cause infertility, but if stress is having an impact on the couple, if it's affecting their libido or affecting the frequency that they're having sex, then stress will have an indirect effect on fertility. Marijuana, heroin, MDMA, all of these affect fertility parameters in both men and women. Caffeine is a bit more controversial. So studies have shown that 500 milligrams a day of caffeine, which equates to approximately 5 cups, has an adverse effect on fertility in women. But NICE guidelines have stated that there's no concrete evidence to say that caffeine affects fertility. Nevertheless, the Fertility Hub in the National Maternity Hospital recommends a 2-cup limit per day for women trying to conceive. Vaping has been shown to affect fertility in women, however, nicotine replacement therapy has not. In men, anabolic steroids will switch off natural testosterone production and switch off production of sperm, so they have a major impact. When I was preparing for this webinar, I spoke with one of the clinicians and went through the slides with her, and she's given me a few anecdotes, but she said it's very, very frequently she's coming across situations where the man in the couple has absolutely, it's got azoospermia, they've got absolutely no sperm whatsoever, and they're refusing to, own up and say what was going on. And it takes a number of counselling sessions and eventually to get the man on their own for them to open up and say that yes, they've currently been on or quite recently been on anabolic steroids. So it is very prevalent. Cocaine affects sperm parameters, and for men, saunas and heated car seats can damage sperm. So if you think that the temperature of the scrotum is 1 degree lower than the temperature of the core temperature of the body, and that's because that's the temperature sperm need to grow and to be maintained in. So having heated car seats or going to saunas regularly can actually affect fertility in men. In terms of medications, so as you probably imagine, chemotherapy, which affects the fastest growing cells. Unfortunately, the fastest growing cells in the body tend to be in the reproductive tract. So current chemotherapy, radiotherapy has an adverse effect and can have an adverse effect. In women, antipsychotics are dopamine receptor antagonists. And if you remember from your pharmacology, antagonizing dopamine causes an increase in prolactin, and this prolactin hormone then can interfere with ovulation. In women, spironolactone can affect fertility as well. NSAIDs can affect fertility in that they can inhibit the ability of the ovary to release an egg, and they can also decrease production of progesterone. Now, that's not to say that NSAID women who are trying to conceive can't consume NSAIDs. They can, but only small quantities, not high doses, not prolonged courses. Herbal supplements like ginkgo biloba have been shown as well to adversely affect fertility in women. In men, exogenous testosterone, what I mean by that is like testosterone replacement therapy, similar to anabolic steroids, switches off natural testosterone production, switches off natural production of sperm. Sulfasalazine and calcium channel blockers can adversely affect sperm as well. Antidepressants, bit more controversial, but there's mixed evidence on this, but most of the evidence seems to be towards fluoxetine having an adverse effect on fertility in men. And moving on to investigations and diagnoses. So this graph here shows the 6 regional fertility hubs, so the 3 in Dublin and the 3 maternities, Cork, Limerick and Galway. The referral criteria is women and men have to be between a certain age, and the woman has to be between a certain BMI. And then if the woman or the man has a known risk factor which affects fertility, they can be referred by their GP to the publicly funded fertility hub. or if they're trying to conceive for 12 months and the woman is 35 or under, or they're trying to conceive for 6 months and the woman is 36 or over. That's the referral criteria. For women, it begins with a physical exam. You're looking for things like that may be undiagnosed, like endometriosis, polyps, that sort of thing. What's always done is they check the ovarian reserve, how many eggs are left. And that's quite simple, simply done through the AMH level and an antral follicle count by ultrasound scan. If the woman has an irregular cycle, then they will do a hormonal profile. So as you'd imagine, FSH, LH, progesterone, estrogen, prolactin. Thyroid function tests are done. So thyroid is quite important when it comes to fertility. It's been shown that hypothyroidism is associated with an increased failure rate of fertility cycles, increased risk of miscarriage, and adverse effects on neonatal and maternal outcomes in pregnancy. So that's checked. Rubella antibodies are checked as well, because if a woman is not immune to rubella, then there could be a risk of congenital malformations if she contracts rubella while pregnant. STI check is done as well. For men, as you can imagine, the semen analysis is done. And if the semen analysis is abnormal, then they do a full hormonal profile on the man. So that's the first learning objective addressed, but we're going to move on to, what's going to be the most useful part for you to know now today. So the pharmacology of assisted reproductive technology cycles, or ART cycles. Now, you mightn't have heard of this first one here. There are 4 types of ART cycles. And the one you've all probably heard of is IVF. And when you get a prescription for a fertility cycle, a lot of people might say, oh, I'm after getting an IVF prescription. But in fact, actually, quite a lot of the time, it would be this first one here, which is ovulation induction. So this is a step before IVF. The ovulation induction is when medicines are used to stimulate the ovaries to release eggs in women who do not ovulate spontaneously. Very often, a number of cycles of ovulation induction will be done before moving upwards onto IVF. The publicly funded fertility hubs now offer unlimited cycles of ovulation induction as well. So that's just something to point out. The next one is intrauterine insemination, or you might have heard the term artificial insemination. This uses the exact same processes and medications as ovulation induction, except the difference here is that instead of the couple having sex once the woman is ovulating, in this scenario, sperm is placed directly into the uterus around the time of ovulation. So it's the same medications, but a different process. One you've all heard of is IVF. So in IVF, eggs are extracted from the ovaries under a minor surgical procedure. These are combined with sperm in the lab. They're allowed to fertilize, they're allowed to grow, and then the best fertilized embryos are then returned back into the uterus. So there's different medications used in IVF. So you'd still do ovulation induction, but there's further steps after that. The next one some of you may or may not have heard of is ICSI, intra-cytoplasmic sperm injection. Exact same pharmacologically as IVF, except the difference here is that instead of allowing the sperm and the egg to meet in vitro and fertilize, there would be problems with the sperm, and the sperm wouldn't be able to fertilize the egg, in which scenario a single sperm is injected directly into the egg. So this is where there's severe male factor infertility. So we're going to talk about the oral agents for ovulation induction. So with ovulation induction, you're trying to induce, the follicles to grow and release an egg, but you want to have a level of control over it. So you don't want 10 eggs being released, because if you'd had that then and a couple have sex and potentially, you could have multiple higher order pregnancies. So you want to be very controlled, and you really want to minimize how many follicles are growing. So as part of all of these ART cycles, ultrasound scanning is performed, and they're monitoring this, and the cycle could be cancelled if there's too many follicles growing. The first line oral agent you will see now these days is letrozole. So this is an aromatase inhibitor. It decreases estrogen production in the ovaries, and what it does then is it tricks the pituitary gland into thinking there's not enough estrogen, and therefore the pituitary gland increases the amount of FSH, follicle stimulating hormone, produced, and then the follicles begin to grow. It's given for 5 days at the start of the cycle. Adverse effects are what you would expect of low estrogen, hot flushes, mood swings, headaches, difficulty sleeping. The next one you've all heard of as will be Clomid or clomiphene. It's around for about 40 years. It's less commonly used these days. It's an estrogen receptor antagonist in the hypothalamus. Again, does the same thing as letrozole, increases FSH. Again, 5 days orally at the start of the cycle. The adverse effect profile is worse than letrozole, and there's a higher risk of multiple pregnancy with clomiphene. Tamoxifen, same mechanism as clomiphene, given for 5 days at the start of the cycle, same kind of adverse effects. Metformin then, so you might think this is unusual, but if a patient has PCOS, metformin improves insulin sensitivity, and by doing so, it causes the ovaries to produce less testosterone, and then it can actually induce a normal ovulatory cycle. And cabergoline would be you'd less commonly see this only for patients with hyperprolactinemia. Cabergoline is a dopamine agonist which decreases prolactin secretion and thereby induces normal ovulation in people who have this condition. One of the adverse effects to watch out for is valvulopathy, so you'd be very cautious with someone with a cardiac history here. So, contrary to public belief, people think of IVF and multiple pregnancies, and say, "Oh, they had IVF. That must be the cause of it." Actually, in reality, most of the multiple pregnancies that are caused by assisted reproductive technology are caused by ovulation induction, because there's that less level of control over the process. Now, moving upwards then, so instead of oral agents, we can use injectable agents. So this could be used, where the oral agents have failed, or where it's group 1 ovulatory disorders, where it's just the patient just doesn't have enough FSH and LH. So we can directly inject gonadotrophins, FSH and LH directly into the patient. So you see here in this graph on the right, this is the FSH injection given for a number of days. Follicles begin to grow. And what they also mostly give is another thing called a trigger, HCG trigger injection. So this HCG trigger mimics the luteinizing hormone surge, and it triggers the follicles to release the egg. In this graph here, this is an example of intrauterine insemination. So you see here, the follicles are stimulated to grow by the injections of FSH. The trigger is given at a very exact time moment, and then exactly 36 hours later, sperm is inserted into the uterus through intrauterine insemination. Injectable agents have fewer side effects than the oral agents, but they can still cause bloating, things and mood swings. And there's a higher risk of multiple pregnancy. So again, what I mentioned there, there's requirement for continuous ultrasound monitoring, so they have to really closely watch this. There's also a risk of a condition called ovarian hyperstimulation syndrome, which can be quite serious, and I'll talk more about that towards the end. Ovulation induction with the injectable agents. So here's an example of them. Some of you might have come across these. What you'd most commonly see these days is a product that has a combination of FSH and LH called Pergoveris. It's got a ratio of 2:1 FSH to LH. Generally speaking, the dose you'd see starting off would be 150 units of FSH with 75 units of LH. The way prescriptions are written sometimes can be a bit confusing. They might just say 150, but what that's referring to is the dose of FSH in the product. When we were doing prescriptions for the Marian Fertility Clinic many years ago, what we mostly saw was this one below was Gonal F, which is FSH only. So that's been around for a long time. There's a generic of this called Bemfola, and there's a newer FSH only product called Recovel that has less risk of ovarian hyperstimulation syndrome. So these are fridge drugs. These are high-tech drugs gotten through the high-tech hall. Now the trigger, so the one you might have seen if any of you have done a fertility script recently, is Ovitrel. That's the HCG trigger that mimics the luteinizing hormone surge. You might also see Gonasi, or people who've been around for a while, you might remember Pregnal, which is now discontinued a long time. Intrauterine insemination, so you do ovulation induction, you use the HCG trigger, except this time the sperm is processed in the lab and inserted into the uterus after ovulation. It's tend to be used more often in younger couples. It wouldn't really be used in older couples. They'd probably go straight in for IVF. It's less expensive than IVF. Indications would be psychosexual issues where the man can't get an erection sufficient to have intercourse, physical disability, previous surgery to the cervix, whereby the cervix can't open up and the sperm can't get through, or donor sperm for single women, lesbians, or if one of the partners is HIV positive. This is where it gets a little bit complicated, so just bear with me. IVF. So you can read the indications here at the top, but the important part here is that there are 7 stages to IVF. Now, the eagle-eyed amongst you might count 8 boxes here, so I'll explain what's going on here. The green arrows on the right reflect stages where medications are involved, and the little blue kind of starry box there, that represents medication aspects we've covered already. So we've covered ovarian stimulation and triggered ovulation. So these form part of an IVF cycle. There's 2 different types of IVF cycles. There's one called a long cycle or a short cycle. So if I begin with the short cycle, this begins with ovarian stimulation, and then you undergo a process called pituitary suppression. And I'll talk about that in the next slide. That contains medications. Then ovulation, then egg and sperm collection, fertilization, preparation of the uterus. So this involves medication using progesterone as well. And finally, embryo transfer. If we're going with a long cycle, which is less common these days, medications are given before ovarian stimulation with FSH to cause pituitary downregulation. Then you go ovarian stimulation, then triggered ovulation, and so on and so forth. So there's 2 different types, and that's probably one of the main reasons why people can get confused with these prescriptions. So what do I mean when I'm talking about pituitary suppression or downregulation? So when you're doing ovulation induction, you're only looking for maybe 1 or 2 follicles to grow. You want a level of control over it. With IVF, you're not so worried about that. You actually want, say, between 8 to 15 follicles to grow and produce eggs. You want to get as many eggs as possible because a couple aren't going to have sex. There's no risk of multiple pregnancy occurring as long as they're following what they're supposed to be doing. So you want to harvest as many eggs as possible. So higher doses of FSH and LH are given. Now, this causes many follicles to grow and they secrete an increasing amount of estrogen. If you remember at the start, it's the rising estrogen levels that triggers the LH surge. So without a level of control over estrogen, there could be a premature LH surge, premature ovulation, you've lost the eggs and the cycle has failed. So to control this then, what you more commonly see these days is a thing called a short cycle or pituitary suppression. This is where the stimulating FSH and LH are started, and then on day 5, this medication is begun. You can see, most commonly see Cetrotide or Cetrorelix. Starts on day 5 and is continued until egg collection. It's kind of the treatment of choice these days. It's more patient friendly because it's shorter course and has less risk of side effects and lower risk of ovarian hyperstimulation syndrome. The long cycle is a little bit more outdated, but it still has its uses. So in the long cycle, the medications to suppress the pituitary or downregulate the pituitary are given 2 to 3 weeks before the stimulation medications and continue until egg collection. So you might have seen things like Suprafact, Cineral nasal spray, Decapeptyl is used. I've the list of the generic names of the drugs there, but you all would have come across these at some point. Less patient friendly, the side effects are worse, low estrogen, but they've been quite useful for endometriosis and ovarian cysts, if you think about it. So if there's a cyst on the ovary or if there's an endometrial lesion somewhere, if you're giving FSH and LH, you're going to aggravate this. So to such an extent that this cyst could rupture or the ovary could torsion. So there needs to be a level of control. So downregulation before stimulation begins can be quite useful if a patient has these conditions. Unfortunately, there is a higher risk of ovarian hyperstimulation syndrome, but the success rate between both types of cycles is the same. So if we look at the ovarian stimulation triggered ovulation in IVF, so as I said, we want to produce multiple follicles, 8 to 14 eggs, compared to ovulation induction with the aim of just maybe 1 egg. The dose of FSH tends to be higher in IVF than ovulation induction. So you could see as high as 450 units per day of FSH compared to a max in ovulation induction of 225. HCG trigger here, again, you see on the right, I brought back in the original diagram, and this is the Ovitrel, which mimics this luteinizing hormone surge, which causes ovulation. So this subcut injection is given 36 hours before egg collection, and the timing of this is absolutely crucial. In terms of egg retrieval and transfer, it's a minor surgical procedure. Generally, people don't go under general sedation. It's ultrasound guided. Paracetamol can be used for pain, but they will avoid NSAIDs for pain in this scenario because NSAID will decrease the amount of progesterone, and we don't want that at this point in time. The sperm is collected the same day as egg collection. Around 2/3 of the eggs will form embryos. The embryologist then in the fertility clinic will monitor these embryos and grade them based on, low grade to fair grade to high grade. And it says, they'll look at them for 3 to 5 days, but generally it will be 5 days until they wait until the 5th day and then they pick the best embryos to transfer. Ireland and many European countries have a high degree of control over the number of embryos. So in Ireland these days, in a well-respected fertility clinic, they would never transfer more than 1 high-grade embryo. They might transfer, if they don't have any high-grade embryos, they might transfer 2 fair-grade embryos. But what you might see when someone has multiple pregnancies, say triplets from IVF, in general, they've come from another country outside of Ireland where there's not as much level of control over this. In terms of luteal phase support, so this is the next part of IVF that involves medication. So if you think about the suppression and downregulation regimen will deplete endogenous estrogen and progesterone. So there's actually not enough progesterone to build up the lining of the uterus. So we need to supplement that back in using progesterone. So this progesterone is started after egg collection, is continued until 8 weeks gestation, or if the patient has a previous miscarriage or bleed in the current pregnancy, then it's continued for 12 to 16 weeks gestation. The most common one you see these days, first line, is Cyclogest, Pessaries, 400 milligrams BD. You might see Crinone gel as well. Sometimes some clinics might use Utrogestin or Luteinized tablets. Patients tend not to prefer lupinase tablets because it can cause a chalky white discharge. Some centres add in or use on its own progesterone tablets, Dufaston, and some centres will use double progesterone. So what that means is, say, a PV formulation along with a subcut injection. In Ireland, you might more commonly see Prolutex. If a patient is coming with a prescription from the continent, you might see Lubion injection. So that's IVF, and an ICSI is the exact same from a pharmacological perspective. The only variation is that in this scenario, sperm are very compromised, so each egg needs to be directly injected with a sperm. There's a higher risk of congenital abnormality with ICSI. The background rate in the population is 2 to 3%. With IVF, babies are born from IVF, there's a 3 to 4% rate of congenital abnormality, and with ICSI, it's 4.5%. Something to point out, if the problem with the man's sperm is due to a genetic fertility issue, then if a male child is born from this process of ICSI, when that male child grows up and wants to be a father, they too will have to undergo ICSI if they want to become a father. So I'm a very visual person, and I like to see a graph like this that kind of ties it all in together. I'll go through this, quite slowly, but if you can understand this graph, then you've completely grasped all the concepts, the core concept of a fertility cycle. Anything else apart from that is not that important. It's just the drugs in this graph here are most important. So you see up the top here in green, FSH started on day 2, and the little blue line below FSH is the estrogen levels. They're starting to rise, so we want to control that. So then there you go, 5 days in, the GnRH antagonist, this could be cetrotide. This FSH only, this could be going left. So the GnRH antagonist is started. Then day 11, the HCG trigger Ovitrel is given. And then you see here the follicles at the bottom, they're starting to grow, and then the follicle releases the egg when the HCG trigger is given. Egg collection then occurs after that, and at the time of egg collection, progesterone is started. 5 days later, embryo transfer happens, progesterone is continued, and 11 days later, a pregnancy test is performed. And if the pregnancy test is positive, the progesterone is continued on until 8, possibly 12 to 16 weeks. So once you understand that, you've understood an IVF or ICSI protocol. Now, it's not that simple, and lots of the questions that came in on the pre-webinar requests were related to additional medications used. They're not some of the questions. I'll talk about some of the other medications now as well, but I'll just go through these ones first. Most common ones you might see. Oral contraceptive pills. So some clinics will give this to time the natural cycle of the woman to the clinic's timetable. So once the OCP is stopped, 5 days later, a bleed will occur, and that's the day that the follicle-stimulating hormone and luteinizing hormone will be given to the patient. Some places use HRT preparations in older patients to build up the hormone levels and to prepare the endometrium. Testosterone is increasingly used now, so studies have shown that testosterone brings forward better follicles and better quality eggs. Thyroxine can be important if hypothyroidism is present. It's linked with increased risk of miscarriage, so this needs to be addressed before conception. Vitamin D3 and folic acid are often given. Vitamin D3 is associated with higher pregnancy and live birth rates. Folic acid you've all heard of before. Coenzyme Q10 is an interesting one, but studies have shown that it brings forward better eggs, better quality eggs. Aspirin is shown to reduce the risk of miscarriage. Some centers use that. Prednisolone then is limited evidence. Not a lot of places would use this. Theoretically, it's meant to decrease the chances that the body views the growing embryo as a foreign entity, but there's not a lot of evidence for this. Low molecular weight heparins like enoxaparin, tinzaparin, these could be given to older women who are a bit older and are on very high levels of hormones due to the VTE risk caused by the increased hormone levels. Naltrexone, again, very limited evidence. It's suggested that it lowers uterine inflammation, but it's no evidence really for this. Lots of centers vary based on our use of antibiotics. So some centers give azithromycin to clean the sperm. Some centers give doxycycline prior to egg retrieval. But one of the key things, and I think anyone who's seen fertility prescriptions, is that there is very wide variation between clinics in Ireland and even within clinics with consultants. Some of the other things that came up in the pre-webinar questions were one of them is DHEA. So DHEA is a weak androgen. It's a precursor to testosterone and estrogen. It's given off-label, but if you go back onto the AHRRA, European Society of Human Reproduction Embryology, you'll see that there's insufficient evidence for use of DHEA, so it's not make or break for fertility cycle. There's no real rationale for it. Similarly with N-acetylcysteine, things like intralipid, IVIG, again, there's lots of theories as to, how these could affect, a fertility cycle and improve chances of conception, but there's no evidence. So these things are not really that important, so don't get too hung up on them. Risks of ART. So the main one is ovarian hyperstimulation syndrome. So the increased levels of estrogen can affect the integrity of the small blood vessels, causing fluid to leak from the abdomen and ankles, and even in extreme cases into the heart and lungs. It's much less common these days because we can terminate cycles, or if this is happening, freeze the embryos, and the embryos can be used at a later stage, or the antagonist regimens are used as well, which can control estrogen levels. If a patient comes into you and is reporting to you persistent nausea, vomiting, severe pain, thirst, ankle swelling, abdominal swelling, reduced passing of urine, you should have a low threshold for referring this on. Don't try to manage this in a pharmacy. If you have the contact details for the fertility clinic that they're going to, give them a ring, get some further advice there. Depending on the scenario, refer them to the GP, or even could be referred on to A&E. So don't take this lightly. Mild OHSS occurs in around a third of cycles, but the symptoms above, we're talking here moderate to severe, and probably it's around 3% of cycles these days. Multiple births, we've spoken about this, the risk is higher ovulation induction than it is with IVF. Fetal abnormalities. So, as I said, the background rate is 2 to 3% in the general population, but IVF is 3 to 4%, and ICSI it's 4.5%. But it's not actually, they don't think it's due to the drugs. So there's a big study done in Australia that looked at congenital malformation rates amongst couples who had infertility compared to couples who didn't have infertility. And they found then that if the couple who had infertility, if they conceived naturally eventually or used fertility drugs, the rate of congenital malformations was the same. So it seems to be related to the fact that the couple or one or both of the parents have a fertility issue as opposed to the drugs themselves. As you've all probably heard, there's an increased risk of the newborn being born prematurely. In terms of lifetime cancer risk, there's been shown so far to be no association with breast cancer in the woman and no association with cancer in women or children born by assisted reproductive technology. So to date, there are no signals to show that there's an increased cancer risk. The side effects you most commonly will see will be abdominal bloating, headache, mood changes, and menopausal symptoms. Some of your practice points when you get a prescription for a fertility cycle. So timing is essential, especially the trigger, Ovitrel, and the antagonist, things like Cetrotide or the Supercur. These need to be given on exact days, and you can't do the cycle unless you're given on the exact day. So a real practical point would be, to look up in advance, see what's available, and don't start supplying parts of the cycle until you're absolutely certain you can supply all of it. Some patients who've had multiple cycles in the past will be very familiar with the cycle, and they might have leftover FSH and LH stims kept in their fridge in good condition at home, progesterone, different things. So just check with a patient who's had a few cycles what they actually have at home. They might not need everything. In terms of needles, people get a bit hung up on this, but there are 3 types of needles. So if you need to reconstitute something, it's a green needle. An IM injection is blue and a subcut injection is orange. And they're all standardized, internationally standardized. The preparations like Pergoveris and all that, they will usually contain enough needles for the number of doses required. But if you just check on the box of Pergoveris, and if it says 6 needles, it'll say the number of needles in it. But you've worked out that the patient actually might need, for argument's sake, 9 administrations. Then you're going to need an additional 3 blue IM injection needles. But it shouldn't happen too much, but just something to be conscious of is the number of needles. You should be supplying patients with some means of transporting the high-tech fridge drugs home with them as well. So a little cool bag, cool box, alcohol wipes, and consider sharps disposal as well for the patient, because they'll be using lots of needles. Most fertility clinics will go to the nth degree to counsel the patients, and they'll get lots of training there. The manufacturer also has really good support materials. So you'll see QR codes on the products, scan those, and you can see the training videos there. So they're very good. In terms of drug interactions, the main one that would crop up would be in terms of SSRIs and clomiphene or tamoxifen, where SSRIs inhibit conversion of clomiphene and tamoxifen to the active metabolite. So if you have a patient on ovulation induction cycles, had multiple cycles, they're failing, and they're on SSRIs, it's something to consider raising with the clinic if they're not aware of this already. In terms of high-tech medicines, a lot of these are high-tech medicines, your agonists, antagonists, your stimulation medications to trigger. For many years, there's been a lot of fertility tourism in Ireland, where people are going to places like the Czech Republic, Denmark, the UK, and coming back with EU prescriptions. So that's probably going to lessen over time now, as we've now got degree of public funding, but you'll still see EU prescriptions. These are valid, but the prescription must be transcribed by the GP or fertility clinic, and the original prescription and a copy of the transcription should be submitted to the high-tech hub. But if you do get an EU prescription, just the best thing for you to do is contact the high-tech hub in advance and just ask them about the process. So we're going to do a practical example here. So this is an example of a prescription for ovulation induction when, say, this could be group 1 ovulatory disorder where the patient's not producing enough FSH or LH. So you'll see here, Progover's 150 units FSH, 75 units LH per day for 10 days. You've got your Albuterol trigger, and I added in progesterone. Even though I didn't show progesterone as part of an ovulation induction cycle, I put it in here because things aren't that black and white in the real world, and people do different things in different clinics. So this is ovulation induction, and we're going to ask a poll question now. So poll question 1, if you get your calculators out on your phone, and if you can tell me what combination of Progover's pens you need to order from the high-tech hub. So they come in 300, 150, 450, 225, 900, 450. Remember that it's the dose that's required is say 150 FSH for 10 days. So if you want to take a moment there and work out how many Progover's pens you think you need to order, what combination. Okay, so this is a good learning point here. So, only just about, I see 2 pence for. Yeah. So 57% of you got it correct. So if you look at the FSH amount that's needed, 150 units, 10 days, that's 1,500. So if you have one of the pens that contains 900 units, that's fine. So you need another 600 units. So to get that, you're going to use 2 other pens that have the 300, 300 and 300. So you had 900 plus 300 plus 300 is 1,500. If you ordered 2 pens of the 900, then you've got 300 too much. And this is a very expensive high-tech medication. So that's a good learning point there. Now, I appear to have lost control of the ability to move on with the slide.
You could try stop sharing or resharing.
Oh, here we go. That's right. So you see here, these are the pens. So you've got the 900 of FSH, 450 and 300. So if you need 1,500, you've got 900 and then 2 of the 300s. You see here, that's your Albuterol and then that's your progesterone there, luteal support. So the next practical example. So the next poll question number 2 is this an example of a prescription for ovulation induction or IVF stroke ICSI? Yeah, so most people got this right. So you see here, there's your follicle stimulating hormone going left. You've got it's a short cycle here with cetrotide, Albuterol, and cyclogest. So that's grand. The next poll question is, I've answered the next poll question, so ignore it. This is a short cycle, sorry. So I was going to ask, is this a short cycle or a long cycle? That's fine, that's straightforward. So now, how many or what combination of pens of going left should you order? So they're available, it contains FSH only. They're in 300s, 450s, and 900 units. And the dose that's required is 300 units by 14 days. So first of all, work out how many units is that. And then what combination of pens should you use? Very good, yeah. So I'm glad to see people then, if most people have figured out the concept there as well. That's fine. You see here, it comes in 300s, 450s, 900s. You've got your cetrotide, you've got your Albuterol, and your cyclogest. So moving on to the last part of the presentation, the legislative changes. In 2021, Ireland ranked 39 out of 40 in the European Atlas of Fertility. So that was a damning indictment. We're now ranked 12th, and this is on the back of the writing into law of the Health Assisted Human Reproduction Act in summer 2024. So this put in place a regulatory framework. It established the Assisted Human Reproduction Regulatory Authority, set out criteria for provision of treatments, use of donor sperm, eggs, embryos, and situations where surrogacy is permitted. So this was long overdue and well needed. AHRRA was established only last month. It's a new statutory regulatory agency established under the Act. And its purpose is to protect, promote, and ensure well-being of children born as a result of AHR and persons undergoing AHR or intending parents. Their main role is to license the fertility clinics and license the fertility hubs. So there'll be prohibition on unlicensed persons operating AHRRA treatments. So there'll be no more situations where a private consultant, an obstetrician, a gynecologist decides in the evenings or weekends they want to start doing fertility prescriptions. They'll have to have a license, and for this will be regulated and meet standards. The AHRRA will have teeth. They'll be able to ensure compliance of the license holders with the Act. One of the most important roles that's going to emerge now will be treatment guidelines. So this will provide people a lot more clarity than we're used to. Age limits for treatment, consent, the number of embryos to transfer, surrogacy, and then really complicated issues like posthumous AHR, where one of the parents has passed away and could be eggs or frozen embryos. The first thing they're going to tackle is management of hypothyroidism. So there's an awful lot of mixed messages from different clinics and different treatment regimens and different treatment limits. So there's no streamlined approach to that. So the first thing they're going to do is issue guidance on what levels of TSH would require management with thyroxine. Fertility hubs, then, these 6 started in 2022. There's now a 3-stage model of care where you start off with the GP, and the GP refers on via HealthLink to the fertility hub. And then the fertility hub themselves can offer unlimited cycles of ovulation induction, and they can offer one IVF cycle, but this IVF cycle is done through a private fertility clinic, but it's publicly funded. 2 of the hubs are now offering intrauterine insemination because they have an andrologist and facilities on site. The other 4 don't have that yet, but that's going to come as well. For more than one IVF cycle at present, then someone would just need to go to a private fertility clinic, and it costs anything from 6,000 to 10,000 euros. But this service is expanding, and I anticipate in the coming months and years there'll be more than one IVF cycle will be offered. Currently, at present, patients only pay up to 80 euros a month on the DPS for the drugs. It's currently for couples only, and it was only covering primary infertility where you've never had a baby before. It's now offering it for secondary infertility where you have had a baby before. This could be a situation where someone has had a baby many years ago or in a previous relationship, and they're now trying again and they're not able to conceive. So it's now covering that as well. We've been through the referral criteria, but just again say if there's known cause of infertility, or if the woman is less than 36 years of age trying to conceive by 12 months, or greater than 36 years of age or over and trying to conceive for 6 months or more, then they get referred onto the fertility hub. Some statistics then. So from September 23 to August 24, you can see how many referrals happened in the year period. The majority were for IVF and ICSI. Now, as of this month, nationally, there are 525 referrals per month. So it's really ramping up, and it's continuing to ramp up. In the National Maternity Hospital alone, we're receiving 100 to 150 referrals per month. It comes in from the GPs via HealthLink, and it's reported a 38% success rate in patients who've been referred over the past 2 years. And that's it. So finally, some key takeaways. The prevalence of infertility is rising over the past 20 years, and with that, you're going to see an increase in fertility prescriptions. Female age is the most important predictor. There are 4 types of ART. We've gone through these at length, but hopefully from this presentation, you can now understand the difference between the 4 different methods. For you as a pharmacist, timing is essential. Absolutely ensure all the medications are available on time. You'll need very often to calculate the quantity and combination of FSH or FSH and LH pens required. And sometimes you may need to calculate how many needles are required if there aren't enough in the boxes. AHRRA are on the scene now, and they're going to begin regulating and licensing, and they're going to start releasing treatment guidelines. So this will make life a lot easier for everybody. The public funding is now available. The fertility hubs are expanding, currently doing ovulation induction. Some are doing IUI. All are offering one free cycle of IVF in a private clinic, but this will likely expand into the future. And that's it. So we might move on, Mary Claire, to questions and answers.
Thank you, David. That was such a systematic way of presenting that really complex subject. So thank you for that. And it was so easy to follow. 2 questions so far in the chat box. First, in Superfact has a warning, men only. Would that be okay for women? And this person's heard conflicting answers from medics about that.
Yeah, I mean, Superfact has been used for many, many years for women for the down regulation. I have seen that on the box. It's, to be honest with you, I don't know. I think it's used. Yeah, it's licensed as well for use in men with issues with their prostate. But no, it absolutely is used in women. So that warning could be disregarded. Yeah.
Okay, thank you, David. And the second is OHSS, a medical emergency.
It depends. So some of the side effects of these drugs are say, likes of bloating, abdominal bloating, and that's slightly normal. The increased estrogen levels cause leaking of the capillaries, and there can be a bit of abdominal bloating. When it's a medical emergency, particularly if someone is extremely thirsty, there's real noticeable abdominal bloating. It could be swelling in the ankles, the really severe nausea, vomiting, all those sorts of things. That's when it's a medical emergency. If someone does come into you in that scenario, depending how bad they are, but if you're able to, and if you have the contact details for the clinic and you're able to get through to them quickly, contact the clinic first and take guidance from them. Otherwise, you've got to, GP at the least, but have a low threshold for calling an ambulance with someone who's coming in with severe ovarian hyperstimulation syndrome. It can be life-threatening.
Okay, thank you for that. I don't see any other questions in the chat at the moment. What I might do is just remind people about our upcoming webinar and also remind you of the feedback survey and see if we have any questions after I've taken care of that bit of business. Thanks, Grace. So we'll put the link in for the feedback survey again. And so if you have anything, any feedback with this webinar or request for future webinars, please do let us know. Again, a friendly reminder that this is obviously such an excellent webinar this evening, and certainly was an aspect of my professional learning that I needed to address, and so it's a good opportunity to start and complete a CPD cycle around this in your own time. And then finally, our upcoming webinar in a few weeks' time is on weight management medicines with Dr. Jean O'Connell, and that will be our last one before Christmas, and that's in 2 weeks' time, and invitations will be issued to that in due course from the IAOP. As always, you can follow the IAOP through various social media on the screen there if you don't already do that, and that's an excellent way to stay in touch with webinars that are taking place. The recording for this webinar will be posted on the IAOP website in the coming days. David, I'm not sure in terms of sharing content, what your position is on that.
That's fine, yeah, no problem.
Yeah, so and I'm looking at Grace as well in terms of circulating that to attendees after the event as well. Is that the plan? Yeah, great. Okay, thank you for that. If there are no other questions, then thank you very much for everyone for attending this evening. Thank you very much for David for putting together that content that was so comprehensive and really a nice pace as well, for easy to follow, and the questions at the end were so helpful as well to clarify learning. So thank you very much. Good night, everyone, and we'll see you in a few weeks' time. Mind yourselves.